हम्म. Hi, good evening, everyone. Good evening. Yeah. So diagnostic, I'll discuss DPL. I'll discuss DPL. Don't worry. So Venkat is demanding DPL. So I'll just discuss. Before that, hi everyone. I welcome you all to Unacademy. So let us just start with the session. And good evening, everyone. God bless you all. So before that, do not forget to join these beautiful batches which have already started. Let me tell you about them. So we have a batch which is starting tomorrow, NEET PG 2022. It's a must attend revision batch, and we also have the FMG batch also. So without wasting any time, let us just start with this question. And let me since there's a demand of DPL, so I'll discuss one question on DPL also. I'll discuss one question on DPL. Okay. So answer me this question. A patient presents to ER following RTA. The patient has been instilled with 1 liter of warm saline intraperitoneally. Following is the image of the procedure. Comment on the procedure, the indication, the contraindications, and the diagnostic criteria. So this golden pearls. Today we are going to discuss a very interesting question. So what do you think it is? Okay, so let us start. Very good, Meenakshi Bichi. Very good. So this is a question on DPL. Let us start with this. When we talk about DPL students, what do you mean by DPL? The term DPL, the term was given by Roots. Roots gave the term DPL. Point number 1. It stands for Diagnostic Peritoneal Lavage. So Diagnostic Peritoneal Lavage. This is what is DPL. What is the concept of DPL? Let us try to understand. It is investigation for unstable blunt trauma abdomen. Now, why unstable blunt trauma abdomen? Do you know, for stable patients we have a CT, and when we talk about unstable patient, we decide the intervention based upon the nature. If it is because of penetrating injury, we don't waste any time and we directly go for surgery. And if it is associated with a blunt trauma, so unstable blunt trauma, we are in a fix whether should we go for surgery or shall we continue the conservative management. It is in that case when DPL is helping you. Students, nowadays the utility of DPL has been minimized. Why? Because of the advent of a non-invasive procedure which is known as FAST. So FAST has actually replaced DPL, but it is still considered as an investigation for unstable blunt trauma. And the most important point is that it is the most sensitive investigation. It is the most sensitive investigation for hemoperitoneum. Do you know? It is 98% sensitive. So most sensitive investigation for hemoperitoneum. Next is, what do we do in this procedure? Let us try to understand. Suppose we have a patient of blunt trauma and the patient is unstable. Now we want to decide what to do. So what is the first thing that you are going to do? You are going to put a needle catheter. So you introduce a catheter. So now what are you going to do? First thing that you will do is you will aspirate out the content. Yeah. If on aspiration, if you get more than 10 ml blood, or leave it. On aspiration, if you get blood, if you get whole blood, this confirms that there is what? Hemoperitoneum. and the indication is now for the surgery. Now on aspiration, if you get on aspiration, you did not get the blood, what to do? Now push 1 liter warm saline. Why warm saline? In order to avoid hypothermia. Now you instill 1 liter of warm saline, and do you know why do you do this warm saline infiltration? So that you can wash off the abdominal cavity, and if there is blood it should mix, and now you have a fairly higher chance of what you can say detecting it. So this is very simple. After this, what to do? This is absorb. After this, what is that? After the installation of warm saline, there is aspirate at least 30%, and send it for examination. Good evening toe touch. Good evening Soumya. Okay, so examination. But just since you are instilling the saline inside the peritoneal cavity, we say lavage. The intention is diagnostic, and that is why we say diagnostic peritoneal lavage. When you talk about contraindication, absolute contraindication is fracture pelvis. The second absolute contraindication is pregnancy, and the third absolute contraindication is prior laparotomy. So prior laparotomy, pregnancy, and pelvis. Why? This is a blind procedure where you involve a sharp needle, and this can cause an iatrogenic injury. So now when on examination you find certain findings which you consider as what? DPL positive. So how do you see this DPL positive? How do you see this DPL positive results? DPL positive will tell you either the solid organ injury, or will tell you about the hollow viscous injury. So solid organ injury and hollow viscous injury, how do you see it? Let us see this. If it is a solid organ injury, sir, warm saline means at room temperature. You can say the warm saline is considered to be not at the room temperature, but you can say somewhere around 32 34 degrees centigrade. You have to warm it. Basically 32 to 34 degrees centigrade. But the standard saline is at the room temperature. So if possible, if you have the correct, you can say there are some warmers also, saline warmers, which will exactly warm it to what, 37 degree or 36 degree. But at least the saline which you keep should not be causing hypothermia. That is why we have to warm it. So solid organ injury, when we talk about solid organ injury, on DPL assessment, if we have more than 10 ml of 10 ml of whole blood, 10 ml of blood. So if you have 10 ml of blood, that is considered as DPL positive. Meenakshi is asking, kaise? How do we warm the saline? You are asking this. We actually have a warmer where the temperature is set. The water is warmed to that temperature, and there is a thermostat which will fix the temperature maybe to 36 degrees centigrade, and then you will drop your bottle of saline in that. So that will maintain that temperature, and when we want to use that, you can take it out. There are in surgery, during surgery, there are saline warmers also, in which you can which can be attached to the bottle. So they are just like that heating pad like mechanism which will warm the saline to the temperature you want. Are you getting this? So there are two ways. So more than 10 ml of blood, this is one. Or if there is a solid organ injury, more than 1 lakh RBCs, more than 1 lakh RBC per mm cube. Or students, more than 500 WBC per mm cube, or more than 75, it is not 175, more than 75 international units per liter of amylase. Are you getting? It's not 175, 75. Next is, when you're talking about hollow viscous injury, what can you expect here? Let's say hollow viscous injury on aspiration, if you get food particles, if you get stool, if you get bacteria, if you get bile, if you get trace of alkaline phosphatase, more than 2 international units per liter. But in all these cases, the hollow viscous injury is confirmed, and DPL positive, this is an indication for surgery. This is an indication for surgery. So are these points clear? Students, is the concept of DPL clear to everyone or no? So let us go back to this and see. Procedure, I have told DPL. Indication, I have told unstable blunt trauma. Contraindication, I have told. Diagnostic criteria, I have told. So I hope this question is complete. Now let us move to the next question. So I'll share one more easy question with you. Okay. Answer me, what is this? Identify, this is A, B, C, D. Okay, I'll give you one more option. Yeah. This is capacitive coupling also. This is known as capacitive coupling. Very good, Meenakshi. Very good. Let us try to understand what is this. Bache had, suppose this is, if you see, this is insulator. This is the laparoscopic sheath, instrument sheath. This is a metal port. Inside this, you will be having the sleeve, the sheath of this instrument. So this is again a metal. So whenever you have something like metal, insulator, and again a metal, or you can say conductor, basically, what happens? There is formation and accumulation of charge in between the conductor and the insulator. What is this known as? This is known as capacitor formation. And this capacitive charge is actually coming in contact with the bowel. So this is basically an indirect coupling, or you can say conductive coupling or capacitive coupling. Capacitive coupling is a better term for this. Actually, I use this because in one of our exam, this thing was named as conduction coupling. So I use that option for you. So if it is asked in exam, you should be knowing. So, bache, this is a, first of all, defect seen with what? Monopolar electrosurgical units. Yeah. Let us try to understand this. So when we talk about monopolar versus bipolar, what is the classical difference? We all know this difference between monopolar and bipolar. This is very, 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 very simple and straightforward. Let us try to understand that. If you talk about monopolar, this is the machine. Imagine this is the machine. One cable is coming out and it is going inside this electrode, and then this is the patient, and from the patient there is a patient plate via which the current is returned back to the machine. So only one electrode is in hand of consultant. So the current enters the body via this and it is radiated out. Yeah. This is what is. This is monopolar. And bipolar, you know, both the electrodes electrode 1, electrode 2, they are conducting the charge. Yeah. Component of heady are all except sorryful. भी हेदी क्या है? हेल्दी लाइफ? अरे नहीं भाई बच्चे, हम सर्जरी वाले, हम इतना नहीं आता है. अरे हम इतने नहीं है. आपको क्या लग रहा है हम बहुत इंटेलिजेंट है? आर वी वेरी भाई प्लीज डोंट टॉर्चर मी. डोंट टॉर्चर मी बाय आस्किंग दीज क्वेश्चंस. हम सर्जरी वाले, वी आर बैक बेंचर्स. वो आगे बैठने वाले नहीं है, एकदम पीछे पीछे बैठते थे, सुनते भी नहीं थे, सो जाते थे ना. PSM क्लास वी यूज्ड टू स्लीप. आई यूज्ड टू प्ले PSP. Anyways, let us come back. So when we're talking about the complications, of monopolar, first we'll talk about the monopolar. But there are a lot of complications. Why? This is the point of entry. This is the point of entry, and this is the point of exit. Point of entry and point of exit. Try to understand this. This is very important to understand this, because the current is floating across the surface and going out. Therefore, imagine if the patient is an underworld don. Yes. And his name is, suppose, Osama bin Laden, CB. Osama bin Laden. What will happen? But the charge, since this is a metal piece, the charge will be conducted along this, and there will be a permanent tissue, a scar here with a tattoo of what? CB here. But I'm just saying a logic. So this is what is known as remote burns. But remote burn is most common complication of any monopolar electrosurgical unit. Are you getting this or no? So wearing a metal is a curse when you're using this. So that is why we advise the patient to leave all the ornaments out. Are you getting this or no? And but just based on this concept, we'll see a lot of things. If you forget the patient plate, again, so if you forget patient plate, again you will have the same thing. You'll have a remote area burn. Now, what are the specific complications? This is point number 1. The second is channeling. Have you heard of channeling? Can anyone tell me? Let me tell you. This is burn associated with passage of current via narrow passage, via narrow exit, like in case of penis. Do you know during circumcision or any penile surgeries, yeah, avoid using what? Avoid using diathermy in form of monopolar. Why? Suppose if you are using a monopolar electrosurgical unit, what will happen? The charge will collect here and it will have to exit. The exit is via narrow root of penis. And when it is via narrow root of penis, you know what is the concept of monopolar electrosurgical unit? The current is concentrated on the tip. Why the current is concentrated on the tip? If you see the patient, if you see the first electrode, it is always pointed. Why it is pointed? Why the electrode is pointed? Because we utilize a point that the concentration of charge will cause steric hindrance, and if there is steric hindrance, there will be what? Generation of heat, and this heat will either cut or will seal. This is the concept that we utilize. Now, bache, you are yourself inducing that phenomena. Why? When the current is moving out via the narrow root of penis, this is going to cause destruction and therefore permanent damage to nerves, damage to nerve, and along with that there will be a burn over the skin, and therefore impotency can happen. Is this clear? So if you have to use, you will use that bipolar, not the monopolar. Steric hindrance means, suppose bache, there is a road and lot of vehicles can pass through this. Now if I narrow this road, there are a lot of vehicles who want to enter, but only one can pass at this time now. So I am creating a geography that is steric. The geography is creating a hindrance. That is what is steric hindrance. This can happen anywhere. Generally, you must have studied this word in chemistry. So steric hindrance is a word where you have a narrow exit, or you can say a clustered scenario where the charge will collide and generate heat. We utilize this. This is a blessing for us because we are utilizing this. Suppose this is the electrode, the tip will have the concentration of charge, and that is why it will be helpful in cutting and sealing. And that is a curse also in certain cases, like if you are doing a surgery on the penis, the current has to pass through a narrow channel, and that is why we always call this phenomena the phenomena of channeling. Is this part clear to everyone or no? Then in laparoscopic surgery, we have a lot of problems. What is that? So special injuries in laparoscopic surgeries. But they are more frequently seen here. Now the first is conduction, or you can say conduction failure. I'm written conduction, right? Insulation failure. What do you mean by insulation failure? Imagine this is your instrument. If you see the instrument, this is the insulator sheet. Yeah? This is the insulator sheet, and then you have the metal rod inside, and then you have the handle or the ratchet, and here you can attach your monopolar cable. This is the cable through which the current enters. Now imagine if this insulation sheath is broken at a place. So it is damaged. You're getting this? And now this bowel is in contact. Now you are holding a tissue, and the current is going through this tissue to this tissue also, but some current is also going to this bowel, and therefore injury happens. This is what is known as direct coupling. This is what is known as insulation failure. The second is, I will tell you about direct coupling. What is a direct coupling? Try to understand. Suppose you are using a hook. This time you are aware, and you know that this is a hook. This is a metal sheath. Yeah, no problem with the insulation. Insulation is absolutely fine. You have the cable attached, and you are now, and this is the port. Normally this should be the location of port, but यहाँ पर ऐसा नहीं होता. There are some people who don't know this logic. This is the metal port, and now you have to introduce the instrument. So majority of their instrument is out. And they are cooking a tissue. They are cooking a tissue with the metal part touching the port. So the metal part of instrument is touching the port. What will happen? The port is also metallic. Since the port is also metallic, what will be the consequence? The current will be all along the surface, and suppose a bowel is coming in contact, this will cause a remote burn. So remote burns are very common in laparoscopic surgeries if you don't follow the correct ergonomics. So is this direct coupling and insulation failure clear to everyone? Yes or no? The next is, the third is, we have the concept of conductive coupling, or you can say capacitive coupling. Let us try to understand the concept of capacitor. So capacitive coupling, I've already told you one very interesting thing. If there is a combination of metal, then insulator, and then again a metal. So metal, insulator, and again a metal. What will happen? There will be accumulation of charge. Bache, you will say, sir, here no insulation failure. I said no insulation failure. Sir, will this form in every surgery? Yes. A capacitor is formed in every surgery. But do you know what is the advantage of using a metal port? Suppose this is a metal port. Can you see this is the metal port? Let me introduce it more. So this is how the port is. Yeah. Now you have an instrument. This is an instrument which is going inside. Okay? And then you have the metallic sheath also inside. Yeah. You have a metallic sheath also inside. Okay, this is the instrument. But the moment the charge is formed, the charge is radiated in this case, because here the charge is not enormous. So capacitor formation occurs. And the charge accumulates. Where it accumulates? It accumulates in between the instrument and port and metal port. But now what will happen? Now from here, since it is a all metal port, the charge is quickly dissipated. It is quickly dissipated on the abdominal surface, onto abdominal surface. What do you mean by this? The charge quickly dissipates out onto the abdominal surface, and from here it will be collected by the patient plate and will be dissipated off. Are you getting this? Is it stuck? Okay, try to see it again. The charge which is formed is going to be dissipated along the abdominal wall. Now imagine, therefore in all metal port, capacitance or capacitive loss or injury is rare. It is minimum in all plastic ports. Nowadays we have plastic ports also, no? Have you seen plastic ports? I have shown you, I think, the XL, Endopath XL 12 mm I have shown you. So in all plastic port, the formation will not occur. But still, if you are using reusable metal ports, because that is cost effective, don't use a metal port with the plastic cuff. It is maximum in case of, earlier these ports were available, metal ports with plastic cuff. Now they are not. Is that clear or no? So this is okay. So these are the injuries which are caused because of the monopolar. I have already explained you in nutshell. Again, I will revise it for you. When you talk about the monopolar has two concepts. It can cut also, it can seal also. So it can cut as well as it can seal. If you talk about cut and seal, what color code is represented by for the cut? Yellow. What color code for the seal? Blue. So yellow and blue. Are you getting this? Next is What is the concept of voltage? What is the concept of voltage? Voltage is high voltage is high in case of seal. Voltage is low in case of cut. What about the current frequency? The current frequency. The current frequency is high in case of cut and low in case of seal. I'll quickly revise with you the mechanism also. Suppose this is the tissue. The moment you touch the tissue with the active electrode, what will happen? The current will flow in high oscillation and low voltage. So high oscillation, that is high frequency, this is going to result in ionic turbulence. And because of this ionic turbulence, what is going to happen? There is collision, and because of this collision, there is generation of steam, and you all know that Shakur, hi Shakur, hi. So we are discussing the complications of monopolar electrosurgery. The question was on monopolar, the capacitive coupling, and now we have finished that. I'm just quickly revising the concept how the monopolar works. Yeah, cut and seal. You're from which place, Shakur? Okay, so generation of steam, and you know steam will cause expansion. So expansion, and because of this expansion, the tissue will blast off. The tissue blasts off. So, bache, the cut concept of electrosurgical unit is based on that bomb blasting technique. You're blasting of the tissues. You are blasting of the tissues. Are you getting this? Next is when you talk about this concept of seal. What is the concept of seal? When you are touching this tissue and you are passing the current in high voltage, low frequency. So the high voltage causes instant melting of collagen. It is going to cause melting of collagen. And when there is melting of collagen, by the time the melted collagen could have converted into steam, what will happen? The current is off because you have low frequency of current, isn't it? But high voltage. So the collagen cools. And when the collagen cools, what is going to happen, students? There will be remodeling. Is that clear or no? Remodeling. And this is going to result in a scar. Now there are a lot of people who are morons. Why? Surgeons are often moron. Whenever you start sealing a tissue, you should be happy and confident with this pink color changing to hash brown color. So pink color changing to a hash brown color is sufficient. But there are surgeons who don't understand this. In order to be very secure or extra secure, they keep on pressing that button. So if you actually reheat this remodeled collagen, what will happen? This scar will actually change its color to this, and then ultimately it will form a what? A charcoal. And once it forms a charcoal, it will slough off. So it sloughs off and therefore rebleed. So whenever you see the blackish tissue, always understand that this place is hemostatically not stable and secure. The next is pure cut is always dangerous. So we don't use the cut in the pure form. Always remember, in order to have a better, you can say, or a safer profile, we use the cut in a what? Blend mode. So cut can be pure cut. What do you mean by pure cut? 100% on cycle. What do you mean by 100% on cycle? Like if you are pressing the pedal for 4 seconds. For 4 seconds, the current is oscillating and it is what? Dividing and blasting the tissue. And that is why it is advised to use this in what? Blend mode. So we are advised to use this in blend mode. Now when you talk about blend mode, you are going to blend the on cycle with off cycle. So you're going to blend it with the on cycle with the off cycle. So blend 1. What is that? 50% on, 50% off. Blend 2. 40% on, 60% off. So can you see? Blend 1 is safer than pure cut. Blend 2 is safer than blend 1. And then blend 3. 25% on and 75% off. One again very important point that you all have to understand, that do you know in coagulation, in coag or seal, we have only 6% on and 94% off. Are you getting this? This is how the seal works. So this is why the seal mode is sealing, and the cut mode is having a different orientation and it is causing bleeding. It is cutting but at the cost of tissue bleed. So next is, let us move forward and discuss one more important question. I hope this is clear to everyone. So let me discuss. Okay, tell me, what is this? Let me tell you, this is anal canal. Identify the lesion. I am still undergraduate student. I can't cope up with what? Esra, what you cannot cope up with? And you're from which place? Don't worry, lot of students are having that medical, you can say stress, medical fatigue, but this is wrong. But you don't take undue stress on yourself. Don't take. The life is very small. Yeah, very good Meenakshi. Very good, very good, very good. It's a intersphincteric. Intersphincteric knee. But anyways, you have answered it. I have understood that you're trying to say that it's a fistula in ano, but it's not intersphincteric. So this is a case of fistula in anus, and that is why we say fistula in ano. Fistula in ano. Very good, Samir. Yeah. Very good, Samir. So fistula in ano. Why it is a fistula? Because it's a tract. There's a tract with two openings. With two openings. One opening is at the level of dentate line, and the another opening is at the level of skin. So let us try to understand the concept of fistula in ano. But in order to understand the concept of fistula in ano, you have to first understand the concept of analapses. Analapses. Now, what is the concept of analapses and fistula? Let us see. If you see this diagram, this is the anal verge. You have the dentate line. Do you know that the internal sphincter, this is where the internal sphincter is. This is where the internal sphincter is. And this is the external sphincter. So how do you define internal sphincter and external sphincter? This is external sphincter. This is external sphincter, and this is internal sphincter. Okay. So external sphincter versus internal sphincter. Let us try to understand. External sphincter is a continuation. It is a continuation of what? Levator ani. It's a continuation of levator ani. Are you getting this? Internal sphincter is a continuation of inner circular muscles. Inner circular muscles. Now try to understand that in between these two, I'll show you. Many a times I have taught this. I'll show you the image also. Don't worry. So try to understand that these are glands. So intersphincteric glands. Intersphincteric, in between the two sphincters, you have anal glands. Anal glands. And what are these anal glands doing? They are having an opening at the level of dentate line. So important is anal glands open at dentate line, and what is their function? Their role is to keep the anal canal moist. To keep anal canal moist. Anal canal moist. And this is very, very, very important. And thus this moisture prevents the damage of the anal canal. Now important is suppuration. So suppuration of the cryptoglandular tissue, this is going to result in collection of what? This is going to result in formation of abscess. Now use your common sense. If this is the anal canal, this is the external sphincter. By default, if there is a collection, this collection is going to gravitate down or no? And therefore you have a painful bulge around the anal verge. So this is the anus, and that is why this is known as perianal abscess. So perianal abscess, this is the concept. But say anyhow, if this is able to cross the sphincter, if this is going to cross the sphincter, this is what space? Ischiorectal space. Ischiorectal space. Then what it will be known as? This will be known as ischiorectal abscess. Ischiorectal abscess. Students, if anyhow it is located high and it goes above the levator ani, what is this known as? This is known as supralevator abscess. Supralevator abscess. अब एक बच्चे कह रहे हैं सर, what is the utility of teaching this in context with fistula? We know that in treatment of choice is incision and drainage, but the logic is there are a lot of people, when you advise them incision and drainage, they don't undergo, they're not ready. And what happens? They start taking antibiotic one after another, and ultimately, if the anal abscess, always remember, anal abscess is acute, and if you don't drain it, so if it is not healed, so non-healed anal abscess, the pus will always find its way out. You know that one opening is by default at the level of dentate line. The another opening will be onto the skin, and therefore this is what is known as fistula in ano. Now one student is saying, sir, how to identify what fistula it could be? We have 4 types of fistula. It could be intersphincteric, it could be intersphincteric, it could be transsphincteric, it could be suprasphincteric, it could be extrasphincteric. So this is very, 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 very important. Now students, try to understand the beauty. How to identify? The question is how to identify. I will tell you a rule. Because there is something which is known as Goodsell's rule. Goodsell's rule is not holding any importance right now because earlier we were not having MRI. Now we have MR fistulogram which will confidently tell us the exact location and everything. So I'm not teaching that. I'm teaching you a trick to remember how to label what is what. Intersphincteric, transsphincteric, suprasphincteric or extrasphincteric. Let us see that. The rule, this is my own dictum. The rule is always look at location of tract of fistula with respect to external sphincter. And this is how the name is decided. What is the rule? Always look at the location of tract with respect to the external sphincter. Ab dekho. Scenario number 1. This is the anal verge. This is the internal sphincter. This is the external sphincter. Are you getting this? There is a fistula with the internal opening always at the level of what? Dentate line. The external opening is always at the level of skin. So how to decide what type of fistula it is? The logic number 1 is stand at the level of what? Stand at the level of dentate line. Stand at the level of external sphincter and ask yourself a question. Where is tract? Where is tract? The answer will be the tract with respect to external sphincter. You are looking, where is the tract? It is in the intersphincteric plane, and therefore this is known as intersphincteric fistulae nano. Are you getting this? The next is, suppose the scenario is not like this, scenario is something different. Just see. Okay. So you have the internal opening at the level of, internal opening is always at the level of dentate line. The external opening is at the level of what? Skin. Now what is this? What is this? Again stand at the level of what? External sphincter. With respect to external sphincter, where is the tract? The tract is going through this. Is it? So what is this? Where is the tract? The tract is intersphincteric. No, this is this time transsphincteric. Are you getting this? This is transsphincteric. The next is, so we have seen two types. The third is, suppose you have, this is the fistula. Let us see this. Students, this is the place where the abscess is. The internal opening is at the level of dentate line. The external opening is at the level of the skin. Yeah. Now where is the tract? Now you are standing here. Where is the tract? The tract is above you or no? The tract is above you, above the sphincter. So this is known as suprasphincteric type. Suprasphincteric type. Then there is one more concept. Try to understand. Suppose this is the abscess. Okay. So by default, one opening is at this line. Then another opening is located high, and this is how the things are. What do you mean by this? Try to understand that internal opening, this is a rare form where the concepts are totally changed, is at the level of rectum. The external opening is at the level of skin. Now you are standing here and you are puzzled because the tract is unrelated to the sphincter complex, unrelated to external sphincter, and that is why you call this variety to be what? Extrasphincteric. Extrasphincteric. If it is going from above, that is a suprasphincteric. A high located fistula not having any connection with this. This is known as extra sphincteric. Samir, is it clear, bache? Is this part clear to everyone or no? बच्चे supralevator कोई नहीं होता है. It's a suprasphincteric. There is no nomenclature like supralevator fistula in ano. Fistula is always named or labeled according to their tract with respect to external sphincter. Is it clear? Chalo, let us move forward. Let us see what is there. So this is a transsphincteric. This is the transsphincteric type. The next is the cause. I have already told you: chronic, non-healing analapses. Chronic non-healing analapses. Clear? Let us talk about the management. This is again very important. Very important. Now, when we talk about the treatment, after the clinical, so whenever you have a question of fistula, after the clinical evaluation, the next concept that we all have to understand is, so clinical evaluation we have done. The next concept is MR fistulogram. MR fistulogram. We go for MR fistulogram. On MR fistulogram, the diagnosis is confirmed. Not only diagnosis is confirmed, also the type is confirmed. The type is confirmed. Are you getting this? The next very important thing is, then is the treatment. In treatment, you can do fistulectomy, that is excision of the tract. Excision of tract. How is this excision of tract done? I'll tell you. Then we have lay open fistulotomy. Lay open fistulotomy. Division of fistula. Division of fistula over a metal wire with curettage of tract. देखो होता क्या है? This is very simple. Suppose let us see this. This is how the fistula tract is. This is how the tract is. So what you will do, first thing is you will insert a metal wire and then you will tie it. Either you can excise it around this, either you can excise it. If you excise it, this is what is known as lay open. This is known as fistulectomy. Are you seeing? This is known as fistulectomy. But the problem here is, in both these surgeries, there is increased risk of anal incontinence. Why you are not taking care of what? Sphincter. And why this anal incontinence happens? Because of the sphincter injury. In lay open fistulotomy, what do you do if this is the fistulous tract? If this is the fistulous tract, you will open up this fistulous tract. And after this, since it is epithelialized, you need to curate it, because if you don't curate this epithelialized tract, it will never heal. The third is what I prefer to do at my hospital is the classical lift. In my plus classes, I have shown the videos also of lift. If you want to see I don't do fistulectomy. I have one video of lay open fistulotomy on YouTube also. You can go to my channel and see there. I have done at least 10 to 15 lifts and they're all with awesome result. What is lift? Ligation of intersphincteric fistulous tract. Why this is considered to be the best? Why lift is considered to be the best? Because you're not dealing with the what sphincters actually. So this is suppose the internal sphincter, and suppose this is the external sphincter. Imagine this is the external sphincter. Let us see, this is a case of suppose transsphincteric fistula. So how do you manage it? It's a very simple way to manage it. What are we going to do? We are going to ligate this tract at two places. We are going to ligate this tract at two places. First of all, where do we make the incision? We are going to make the incision in the intersphincteric plane. So make the incision in the intersphincteric plane, and then you need to divide this fistulous tract. You need to divide this fistulous tract. So ultimately you will see you have excised of this part. The fistulous tract is ligated at two places and the tract is disrupted. Also, what I do is my modification. When I am doing lift, I do a SD's modification. What is SD's? SD is my logo. So I have tried to now innovate some surgeries, and I have seen that this is far better than the conventional lift. देखो lift बस इतना होता है. What is lift? Dissect the intersphincteric space, dissect intersphincteric space, identify the tract, identify the tract, just a minute, yeah. Identify the tract and then ligate the tract and divide it. What I do in my procedures, I do my modification. After this, I will also do external tract curettage. Because this is what is pathological. The internal tract was always there. Are you getting? So what I have done in my surgery, I have combined or clubbed the Hanley's management of a horseshoe fistula. They do that very same thing, and a lift. This is my modification, and wonderful results I have. And after that we have the last is setons. What is setons? They are the drains. What is a fistula? It's a non-draining analapsis. So the drain placed along the fistulous tract. And what is it going to do, students? The aim is to facilitate drainage, and therefore reduce suppuration. Next very important thing is, this is indication elderly, not fit for surgery. So elderly, not fit for surgery, pregnancy, immunocompromised. But see, there is one more version of setons. So this is what is the concept of draining setons. We have something which is known as cutting seton also. What is the concept of cutting setons? These are proline sutures. Placed. This is what is, I think, Shastra, which the homeopaths and Ayurveds and everyone, quacks, they follow. So proline sutures placed across the tract with sequential tightening. What is the concept of the sequential tightening? We want to, the aim is conversion of high-lying fistula into low-lying. And once it is converted into low-lying fistula, and then definite treatment. This is what. So students, this is all for today. I hope you enjoyed, and if you enjoyed, do join the plus, use the code Dr. Dixit, or you can use the code Surgery Life. You can use any of them. Do join the plus program. It's wonderful. Whatever you are enjoying here is just the 10% of the content. Unacademy is the most, you can say, advanced platform in terms of educators, in terms of technical, you can say, support, as well as the app. So do make use of. We have a lot of interesting thing for you in the plus program. And yeah. And always one more thing. Try to recommend your friends to join the sessions. Do follow me on Unacademy so that you don't miss notification of my classes. Just give me, Meenakshi, a minute. I'll show you monopolar, bipolar, everything I'll show you. Just a minute. I've taken a lot of classes on this monopolar, bipolar concept. Just give me a minute. I'll show you. Okay, just see. This is what is a bipolar. Why it is a bipolar? Because both the electrodes are in the hand of the consultant. Can you see? This is like a form. Both the electrodes, electrode 1, electrode 2. This is a bipolar. Is that clear or no? Now, if I convert this into a single electrode and there is a patient plate attached, this will become a what? A monopolar. Is that clear? This is how we convert. This is a monopolar in front of you, and this is a bipolar. Monopolar, one electrode in the hand and one patient plate. In bipolar, both the electrodes are in the hands. This is a bipolar. Is that clear or no? And you can search my energy sources, modern era energy sources class. In that I've shown instruments also at a detailed discussion. So I hope if you enjoyed the class, do follow me on Unacademy so that you don't miss notification of my classes.